So let's move straight to session one with Dale Ischia. As I mentioned, she's an exercise physiologist with an incredible amount of experience, over 20 years, and she completed a cancer exercise training course in the US at the American College of Sports Medicine. She returned to Melbourne in 2014, where she started Moving Beyond Cancer, an incredible facility that's really designed to help oncology patients with their specific needs for exercise, and with a group of very experienced trainers. So with that, I'd like to hand over to Dale, and let me.
There we go. Oh, that's exciting. There we are. Well, thank you so much for having me. I am so impressed that anyone's joining me and not watching Lego Masters tonight. So I hope I can entertain you. I would much prefer to be speaking to you all in person, because it's very awkward staring at yourself on a screen and not getting any visual feedback and knowing if anyone's actually listening to me. So hopefully you will continue listening to me. I won't get too distracted by myself, by my own company, and I can give you some good information. So yes, as Keone said, I've worked with people with cancer diagnosis, prescribing exercise programs for them. So I'm just going to talk to you a little bit about why that's important and how we go about it. So, hello, how do I move on like that? So this is a illustration of the brochure that I designed about 5 or 6 years ago now, just discussing how exercise can help during cancer treatment. Obviously, there's some wonderful topics there that we can restore aerobic capacity, improve mood, reduce cancer-related fatigue. But I was really happy to be able to update this brochure a couple of years ago to include that exercise can also improve the efficacy of cancer treatment, tolerance to treatment, and also improve immune function. So I'm going to be talking a little bit more about that in a moment. So cancer and its treatment is like this perfect storm of deconditioning. Basically, you've got the cancer itself, you've got the normal aging process, typically sedentary behaviour. You might combine all different treatments such as hormone, chemo and radiation treatment, and you've got this enormous deconditioning process of all systems of the body, not just the musculoskeletal system, but the cardiovascular system, neurological system, everything. So I just want to talk a little bit about the cardiovascular system and the fitness. So we use cardiovascular, well, the reason why cardiovascular fitness is so important, and hopefully one day we're actually going to see this used as a tool to decide whether or not someone's actually fit enough to undergo chemotherapy, is at the moment there's not really an actual process that's in place, but I think it will one day be in place that if someone has a cardiovascular fitness score or VO2 score of less than 14, they won't be allowed to undergo chemotherapy. So when you do undergo chemotherapy, it's similar to a decade of decline in terms of your cardiovascular fitness. So that's pretty massive. And this can be further impacted by thoracic radiation to the lungs and also cardiac abnormalities. And it can be again impacted by a reduction in red blood cells and hemoglobin. And of course, sedentary behavior reduces your VO2 or your cardiovascular fitness. And it's a predictor of cardiovascular disease mortality, of course, and also all-cause mortality. So some big randomized controlled trials were undertaken many years ago now, where they were actually able to stop this decline in cardiovascular fitness in women undergoing chemotherapy for breast cancer. So stopped that 12% decline. Whereas these guys with Lee Jones were actually able to increase cardiovascular fitness by 12% during chemotherapy, which is significant. And we've seen this in our own private practice. And the difference is in the exercise prescription. So Jones introduced interval training with increased intensity, right? Whereas a lot of the initial interventions were very low to moderate intensity, not wanting to upset anything in the cardiovascular system, basically. But then now we're seeing more and more increasing in intensity with our interventional studies. This is just a nice illustration of how cancer treatment can induce bone loss. So I don't know if you can see my pointer, but obviously there's a massive bone loss in women with breast cancer who are undergoing any treatment that's suppressing their estrogen. Also, the same goes for men on ADT, androgen deprivation therapy, reducing their testosterone. We've got a big increase in bone loss. So ideally, exercise will try to or aim to stop this bone loss, or at least slow it down. So there's a lot of evidence out there regarding exercise, and some of it's really strong evidence, and some is you know, associated evidence. But the strongest evidence at the moment is that exercise is the most effective treatment against cancer-related fatigue. It helps significantly with depression. It improves quality of life. It can stop the loss of bone. We can improve body composition, such as muscle mass and reducing fat mass, or muscle mass is probably the most important thing in most instances, because it's a good indicator of survival as well as your muscle mass. We can restore range of movement, obviously after surgery, such as a breast reconstruction. That's very important with regards to cancer. Improving pelvic floor function. We know that exercise is very effective with that, and we stop the loss of strength and the loss of cardiovascular fitness through exercise, and we can not only stop it, but we can improve it. So this is I'm just going to see if I can move my own little face over here somewhere. Here we are. So this is a study, an enormous study undertaken it's a systematic review looking at about 50,000 cancer survivors of people with breast and colorectal cancer. And the conclusion was pretty significant. Those who were physically active after breast cancer diagnosis, so I'm pressing the wrong button again, had a 48% greater chance of overall survival and an 18% greater chance of breast cancer survival. And those that exercised before and after diagnosis had the lowest risk of death. This was another really significant study in our field, but it was a retrospective study of around 2,700 men. And they worked out that if these fellas exercise, or those men that did exercise for more than 3 hours per week of vigorous intensity exercise after their prostate cancer diagnosis, reduced their risk of dying from anything by 50% and from dying from prostate cancer by 61%, which is pretty compelling. And the men exercising vigorously before and after diagnosis had the lower risk of death, similar to the previous study. So there's been a lot of mice studies recently, which are very exciting, but should be viewed with cautious optimism, because they have been undertaken in mice, not yet in humans. Siri thinks I'm talking to it. Hang on, go away, Siri. So this study was, again, mice with breast tumour cells. Breast tumour were implanted into 24 mice, and they were randomised to an exercise group and a sedentary group. In the exercise group, the tumour growth slowed, Perfusion increased, so the oxygen delivery through blood vessels increased in the exercise group. So that's the theory there is you can bathe your chemotherapy, bathe the tumour with chemotherapy better if there's increased perfusion. And apoptosis increased. Apoptosis is where a cell voluntarily kills itself when it decides there's something wrong with it. So we want that. That was good. Reduced hypoxia, which is the opposite of perfusion. So exercise plus chemotherapy prolonged growth delay compared to chemotherapy alone. And there's some lovely little graphics here. So this picture here with the green and the blue. So the green demonstrates the apoptosis. So in the exercise group, you can see there's a lot more apoptosis. The tumor volume you can see in the exercise group is lower than the sedentary group. And I think I've got, some pretty cool slides here as well. I don't know if I'm moving myself around for you as well, but anyway. The one with these actual tissue samples is probably the most compelling. Looking at the control group, the black mass is obviously the tumor cells, so a significantly less amount in the exercise group. I am aware that I've only got 30 minutes, so I should not dwell too long. So this was a really exciting study. I'm particularly excited by this. I'm very interested in bone metastases because that's something we need to consider as exercise physiologists quite a lot, whether how safe it is when someone's got a bone metastases, you know, how much can we load them? How much can we exercise these bones? It's something very important to us. So this was a really exciting study where they got these poor mice and loaded their tibia, so a compressional force on the tibia, which you can see in this top diagram. And I think, it was 6 weeks of compression force, the poor little mice. But you can see here in these illustrations that, go away Siri, that those in the loaded group with the tumour had significantly less degradation and tumour formation, which is really exciting. So, you know, all the studies that have been undertaken so far, we've you know, been overly cautious, as you always are in a study, and avoided bone metastases, but now these sort of things are giving us the confidence to start loading bone metastases in a safe way. Also, I just wanted to touch on exercise and immune response. We know that low to moderate intense exercise is beneficial to our immune function, but if you're exercising at a long duration with really high intensity, it actually is detrimental to your immune function. So this slide here is just showing that how natural killer cells are recruited into the bloodstream during exercise, and this peaks at about 30 minutes of intense exercise, and after 3 hours there's a decrease. So the main function of our natural killer cells is to kill you know, malignant cells. So just to summarize, move myself around again. The cardiovascular decline caused by cancer, or the treatment of cancer, can be stopped and improved by exercise. People with a better body composition have an increased chance of survival. There has been studies done on that, and you can imagine that those with a greater muscle mass can withstand the rigors of chemotherapy better than someone that does not have a lot of muscle mass. Exercise improves body composition, of course, and it reduces the chance of recurrence, as shown by those studies. It improves immune function if at the correct dose. It's safe for lymphedema. I didn't really talk about that, but we know that it is, and I'm happy to talk more about that. And it's the best treatment for cancer-related fatigue. It's safe for people with bone metastases, and evidence suggests that exercise increases tumour perfusion, thus increasing the efficacy of chemotherapy. So I've convinced you that exercise is fantastic for people going through cancer treatment. So how do we do it? And what should we do? So there's two things. We've got to do aerobic exercise, cardiovascular exercise, and resistance exercise. This is a very simplified prescription and dose, and umbrella dose for anyone that's been diagnosed with cancer, but also any general population actually. But exercise is now recommended by COSA, that it should be a part of everybody's cancer treatment. It's safe and feasible across the entire cancer continuum, and it should be a part of everyone's cancer care. So the dosage is found by, so what mode? So are we going to be doing weight training, balance training, running, walking, bike riding? What intensity are we going to do it at? And that depends on various factors. How often are we going to do it and for how long? But the umbrella thing is 30 minutes a day, 5 days a week of cardiovascular exercise and resistance exercise of 30 minutes a day, 2 to 3 times a week. So just touching more on this cardiovascular recommendations. Blanket rule, avoid inactivity. So you just don't want to lie there and lose all your cardiovascular fitness and muscle mass. You want to try and get as active as you can. But of course, for some people, this is 150 minutes of moderate activity per week might not be achievable at some phases through their treatment or for other reasons. But ideally, at least 150 minutes of moderate activity per week. Or as much as 2 to 4 hours per week to reduce the possibility of recurrence. And we can also equate, because the first 150 minutes is moderate activity, we can also do instead 75 minutes of vigorous activity or a combination of both. And I will touch on what that all means. But of course, it's okay to begin in 10-minute blocks if that's all you can handle. So we can break it up so we can try and achieve those 30 minutes a day in 10-minute blocks. So intensity guidelines. Oh, hello, there's a man in the corner. Tom's in the corner. So moderate intensity is actually pretty, well, sedate in a way. It can be. So we can measure it by your heart rate, and I mean sedate in terms of the heart rate response. So to get our maximum heart rate, just a simplified version is 220 minus your age, and you multiply that by 55% is not very high for someone in their 70s, for example. It might only be 100 beats per minute. So it's not really getting them working very hard. But we also use this perceived rate of exertion scale, because sometimes heart rate is not a really good measure to use. They might be on beta blockers. Chemotherapy itself increases your resting heart rate and your working heart rate. So sometimes it's not the best guide as to how hard somebody's working. So we use this perceived rate of exertion scale. Another simple way is that you can talk, but you can't sing while you're doing it. So walking, you might walk hard enough that you can't sing, but you can still chat, or hiking, biking, and swimming. And then vigorous intensity, we're really getting your heart rate up a lot higher. You can't really hold a conversation at all. Jogging, running, those sort of things, swimming hard. So I think my next slide, yes, is the Borg scale. So essentially the Borg scale is 6 to 20, and it's those numbers for a reason. Essentially, you don't tell the person at the time, but you pop a 0 on the end of that, and that's about where their heart rate is, vaguely. So 6 is doing absolutely nothing, chilling out like the kitten. So getting back to our moderate zone is around this 12 to 14. So you're working somewhat hard, and the vigorous is more 15 to 17. So we're working hard to very hard, running up a hill, that kind of stuff. The strength training guidelines, 2 to 3 sessions per week for your major muscle group. So doing multi-joint type exercises, not just bicep curls. Start low and progress slow. So you want a gradual progression, don't just go crazy. And you're starting with just one set of 10 to 12 repetitions of 8 different strength training exercises, and then you build from there. So you might increase the number of sets, reduce reps in order to increase the weight you're working with. So when we're prescribing an exercise program, and if we have to consider all sorts of things. So when we're doing our initial assessment, we want to know these things. Do they have any comorbidities, any heart conditions, any joint problems? Where are they in their treatment cycle? Are they at risk of any cardiac issues? So we need to discuss, we educate them regarding those risks and what it looks like, and we watch for symptoms. Do they have lymphedema, or are they at risk of lymphedema? Do they have a PICC line or a port? Do they have bone metastases? Because we do need to modify our program if they do. Do they have joint pain? So for example, with getting back to the bone issue, the best exercise for improving bone density or slowing the loss of slowing the bone loss is impact training. So jumping, hopping, skipping. But we can't certainly get someone, a 70-year-old who's just been put on androgen deprivation, who's already osteopenic, to start jumping, hopping, skipping if they've never done any exercise before, and if they've got knee osteoarthritis. So we've got to get them to the point that they're able to withstand this impact training. So this is an important factor for us. And any exercise, any strength training exercise, we need to know if they have any arthritic joints or any tendon issues, which seem to be quite common in the oncology client. Are they at risk of infection? So that depends on what we would be recommending for them in terms of, you'd avoid a swimming pool or avoid a public gym, which of course we all have to do at the moment anyway. What their fatigue levels are like, and there's quite a lot of education we deliver with regards to cancer-related fatigue and how we progress their exercise program if they have fatigue, what their blood counts are like, and are they at risk of falls, or what's their balance like. So a really common side effect of cancer treatment is peripheral neuropathy. So that's going to affect their balance, and that also affects our exercise prescription. So we know that balance exercises can actually maintain or stop the loss of balance, maintain their balance, which certainly helps, because when you've got the peripheral neuropathy and the lack of feedback in their feet, they are at risk of falls, and then combine that with your osteopenia or bone metastases, and that is a situation you don't want to have. So we have to take that into account. So then we obviously prescribe them exercises that are going to challenge their balance, but not challenge it so much that they're going to fall. Blood counts are really important as well for us, specifically anemia. If they're anemic, that's just one instance where we can't push them at all with regards to exercise. And also any scarring from their surgeries or their range of movement limits. So in an initial assessment, this is what we do in our assessments. Just going to move my little face again. So we take a really extensive history and a PAR-Q, cancer history, lifestyle and support, what treatment they're going through or will be going through, their side effects of treatment, what comorbidities they have, Are they doing exercise? Are they an exerciser, or have they never exercised before? And this is their teachable moment. They're finally getting their act together moment. And then we set goals, and we have measurable outcomes. Some of these we can't do at the moment from in video consultations, but typically this is what we would usually do. Taking their blood pressure, resting heart rate and oxygen saturation, their body composition, girth measures, and specifically if they're at risk of lymphedema, we would take their arm measures, and waist measure is a good indicator of their body composition as well. We test range of movement if it's relevant. We take their grip strength, sit to stand, and a modified push-up. We'll test balance. We'd do a FACT fatigue scale and a cardiovascular fitness test, doing a sub-max VO2 and recovery, because that will dictate what level and intensity we prescribe their cardiovascular exercises. I'm just going to do a time check on myself. Oh, jeepers, it's 8 o'clock already. That flew by. And then we prescribe exercise through a program called PhysiTrack. So that's an online exercise prescription software where they get videos of the exercises we've prescribed. So it's really good in terms of reducing the chance of them doing the exercise incorrectly. And we can track them as well, and we can communicate through PhysiTrack, and we can also get them to do like a pain scale or a fatigue scale during each exercise session. We're not going to do this because I can't see you, so forget that little thing, but this is just a sit to stand result and a balance. So what kind of exercise is best? So correct dosage of a combination of the following types of modes of exercise. So we want to do cardiovascular exercise and strength exercise. Impact training for bone health. We need to do balance training for balance, obviously, and if they've got peripheral neuropathy. Specific range of movement exercises. So there's just an example of a simple range of movement for shoulder recovery from breast cancer. But it's important to do something that they enjoy, otherwise they're just not going to do it. So there's no point. It's got to be fun. So with a friend or a group, so we run group sessions to try and keep it interesting and supportive, and encourage that psychosocial benefit of exercise as well as the physical benefits. So everybody should be exercising. It's part of the best medicine, and we hear so often that it's one thing that people can do for themselves and they feel in control for once, and it's got many positive side effects. So I think that's me done. Hang on a sec. Let me just check. Oh yeah, that's just some pretty pictures of our studio. And thank you. That's where we're located. No worries. You're welcome.
That was fantastic. I really appreciate the time that you've taken to share that with us. And I think everyone will agree that Dale is a wealth of knowledge when it comes to the utilisation of exercise for cancer patients. I particularly, the area that I really enjoyed hearing about, Dale, was just about people with bone metastases and exercise, because that's a question that comes up a lot just in terms of concern about risk of fracture. So that was fantastic that you touched on that.
Yeah,
Excellent.
no, you're welcome.